The Department of FaCE, which is the Department of Family, Community and Emergency Care, we call it FaCE just because it sounds cool, was established in 2021 as a result of us having a vision for what generalist training can be, the type of research that we're doing, and also taking the university much closer to the community. So it's a fairly radical reimagining of what health science academia is about. I'm very proud of that, and the divisions that have come together are family medicine, emergency medicine, palliative care, sports and exercise medicine, which is a really interesting addition. And then we have a core primary healthcare team that is our community-orientated unit. So it's a group of divisions that have come together who represent what we would like to term the generalist core of all the medical specialties. They're all young, emerging disciplines. They don't have the 200-year tradition of surgery or pediatrics or internal medicine. These disciplines are all new. They've been born post-2000 in South Africa, and so their identity is very much enthused by the challenges this African population is facing.
What we really want to see at the end of the day is to see a well-prepared, well-grounded health worker that is aware and conscious of the realities that's underlying in the social fabric of the patients that we encounter, but also in terms of transformation, being aware of the socio-cultural dimensions, to have this cultural humility and awareness, how to work in teams, how to work with patients with different worldviews and different languages that you might have, and how to manage that in a way that is at the end of the day conducive to create health and wellness for the patients that you want to serve.
If you are in a space of severe suffering, you require not only the medical terms, but you require the presence psychosocially and spiritually as well. And this is what we're trying to teach our healthcare professionals. This is also something that we are trying to research. And when we're looking at psychosocial interventions and spiritual interventions and medical interventions, we need to be very clear that we are looking at the African context. Africans are not low resource, we are differently resourced.
Many of the African countries do not have well-developed emergency care systems. A lot of their students or a lot of their clinicians come experience emergency medicine here in Cape Town, and with the infill in emergency medicine, we have trained quite a lot of leaders who's gone back and is now running emergency departments, setting up EMS systems in other countries across Africa. Some of them have even developed their own training facilities and institutions after a few years. So we see the product of the seeds that we've been planting for a while.
So sport and exercise medicine plays an important role in the future of healthcare. The vision is that we will integrate sport and exercise medicine practitioners at a primary healthcare level, working with community healthcare workers, biokineticists, physiotherapists, and GPs to optimize healthcare in an integrated fashion for all South Africans. If we look at research data documenting overall mortality and morbidity, we see that exercise is the single most effective preventative treatment for chronic diseases such as obesity, diabetes, dementia, depression, anxiety, and many other conditions, including multiple different cancers, and is also the most effective intervention in terms of treatment for many conditions.
All four of these disciplines are firmly committed to what we call person-centered care. And that's the thing that holds us together, because it means that we cross boundaries all the time. We're not limited by saying, oh no, this is beyond my scope of practice. Because actually, if your patient walks through the door and has a problem, it's within your scope of practice. You may end up referring the patient somewhere else for the final, really extensive specialist care, but you always remain committed to this particular patient and their family sitting in front of you. And that for me is what holds all of these disciplines together.
So the way we do it is to make sure that our students, from undergraduate right through to postgraduate, spend a substantial time within the service platform, and that our students, for instance, at fourth year level, we have an integrated block with public health where they work in community spaces doing health promotion projects outside primary care facilities in community spaces with learning facilitators. And in postgraduate level, our registrars are employed by the Department of Health, but they are linked to a primary care facility or district hospital, and within that drainage area of that facility, with that community, they have community-oriented primary care projects.
We have final year medical students involved in a school program where they are doing health promotion with the learners at the Western High School. So for that, we have had a session with the learners, where we had about 80 learners involved, and the students were actually running health promotion groups with them, with a focus on the problems that were identified during the stakeholder meetings. And that will include things like teenage pregnancy, substance abuse, social ills in the home, lack of support in the home, a high rate of alcohol use among teenage kids, and violence as well that involves gangs that come to the schools. So those are some of the things that we hope that with their involvement, then we can have things addressed.
We're not only looking at giving pills and giving injections, and health is much more than just curative. How do you promote health, maintain health? How do you prevent people from getting sick or making the wrong decisions? How do you help them when they're kind of very sick at the end of life, and what sort of care is needed there, and also how to do rehab?
I engaged with the doctors, I engaged with the facility managers, I engaged with the community members, which is the health forums and the health committee members, and also part of that committee that we had, I would also engage with, we had CHWs that were part of that, and one nurse, and we had a patient and also a caregiver that was part of the committee. So to keep the communication going and to ensure that the community feels part of the program itself.
What we are trying to do is to work harder in terms of engaging with communities for us to co-create the interventions, to co-create the things that communities want, to be connected on a regular basis with communities. So we have community stakeholder meetings regularly where we are telling communities the things that we are doing, the things that we are finding, and getting their insights also around the things that they think should be done, not just by us, but by all of us.
Our massive transformative purpose in FaCE is to build inclusive communities of care together. And we're very intentional about it, because we're building together, and what are we building? Communities of care, which are inclusive. UCT's vision is about unleashing potential, igniting agency, which is also about finding the space for the individual within their community, within the space in which they're going to be thriving. Unlike an individualistic perspective of the world, where unleashing that person's potential is just good for them, we know that in our African worldview, when you unleash one person's perspective, it's good for all of us. But at the same time, all of us have the responsibility to facilitate that unleashing.
We as doctors, as health professionals in general, need to be more conscious and aware of the impact of the environment on our patients. So much so that we need to be aware of how much our hospitals and our workplaces are further causing harm to the environment that our patients are supposed to feel safe and healthy in.